Pain is one of those things that tests the limits of what people can endure. You see it every day, you hear it described in 100 different ways, and yet, no matter how many patients you see, no two stories of pain ever sound quite the same. For the people who walk into your exam rooms, pain isn't just a symptom. It becomes the architecture of their lives. It shapes how they move, how they sleep, how they relate to their families, and eventually, how they see themselves. What I want to talk to you about today is what happens when that pain does more than disrupt a life, when it dismantles it. Because there comes a point when treatment isn't the only thing at stake. Work, income, housing, dignity all start to hang in the balance. That's where your role as pain professionals intersects with mine. I'm not a doctor. I'm an attorney who represents people when their pain has become disabling, when their conditions are no longer just medical challenges, but barriers to survival. And I've learned something over the years that I think you, as clinicians, can appreciate better than anyone. Pain might start in the body, but disability starts on paper. When your notes, your reports, your assessments, the language that you choose end up in front of the Social Security Administration, they tell a story. And that story can either help your patient or hurt them. Most of the time, you're not writing those notes for a lawyer or a judge. You're writing them for continuity of care, for insurance, for yourself. But once a patient applies for disability, your words become evidence. And the difference between doing well and experiencing stable pain with significant daily limitations, that difference can decide whether someone eats next month or doesn't. Now, let's be honest, this is not the part of medicine that most of you signed up for. You didn't go to medical school or nursing school to become experts in federal benefit programs, but here's the reality. The Social Security system leans heavily on you. Social Security doesn't have its own doctors who examine every case firsthand. They rely on medical evidence that comes from you, your documentation, your clarity, your consistency. So what I want to do today is help you understand how your clinical expertise translates into legal strength for your patients, and how a few small changes in language and awareness can make a tremendous difference in the outcomes. The first thing that I want you to know is this. Nearly 2/3 of all disability applications are denied at the initial application stage. By the second round, called reconsideration, about 90% are denied again. That's not because people are faking it. It's because the system is built to look for function, not suffering. Social Security doesn't decide cases based on diagnosis alone. They look for evidence of limitation. They ask, can this person perform sustained full-time work activity 8 hours a day, 5 days a week in any job in the national economy? If the answer isn't documented clearly in the medical record, the assumption becomes yes. That's why words matter so much. When you write patient is stable, that's good news in medicine. It means no acute crisis. But to an adjudicator reading a disability claim, stable can sound like evil. Social Security doesn't read between the lines. They take your notes literally. So when you describe a chronic pain patient, you're not just summarizing the clinical picture, you're shaping how the legal system understands their capacity to function. Now, I want to be clear. I'm not asking anyone to exaggerate, dramatize, or advocate outside the facts. Quite the opposite. I'm asking you to be specific. Instead of patient reports pain, try patient reports constant pain rated 7 out of 10 despite compliance with medication, resulting in limited ability to sit more than 15 minutes or stand more than 10. That's a functional statement. It connects the medical condition to the real-world impact. That's the bridge that Social Security looks for, that lawyers like me depend on. Here's why that bridge is so important. Chronic pain is invisible. There's no blood test for it. There's no MRI that says this person can't work. The credibility of your patient's experience lives in the consistency of your documentation. And I know how hard that can be because you're balancing dozens of charts and you can't write a novel for every encounter. But even one sentence that ties symptoms to function can change everything. For example, patient's pain interferes with concentration, causing errors when performing repetitive tasks, or patient requires position changes every 15 minutes due to lower back pain, or patient's pain results in unplanned absences averaging 3 to 4 days per month. Those details bring the patient's life into focus. Because when a claim examiner or a judge reads those lines, they're not guessing anymore. They can see how the pain translates into limitation. Now let's talk about what often causes good claims to fail. The first culprit is incomplete records. A patient has seen multiple providers, primary care, specialists, and urgent care, but those records don't talk to each other. There's no cohesive story. Second, inconsistent notes. One clinician writes, patient doing well on medication. Another writes, severe breakthrough pain, not functional. The inconsistency raises doubt. Third, compliance. If a patient misses appointments or doesn't follow through with treatment, the record might say non-compliant. But what it doesn't say is why. Maybe they couldn't afford the copay. Maybe they lacked transportation. Maybe the medication side effects made them worse. If you take an extra moment to note the reason, it gives the system context and protects the patient from being misjudged. Fourth, lack of objective testing. I know that not every pain condition lends itself to lab values or imaging, but functional capacity evaluation, 6-minute walk tests, and other objective measures can strengthen a claim immensely. And finally, vague or templated documentation. When every note looks the same, it weakens continuity, it weakens credibility. Consistency doesn't mean repetition, it means continuity with nuance. What makes your documentation powerful isn't how long it is, it's how clearly it captures functional impact over time. Let me give you a practical example. Let's say you have a 54-year-old patient with failed back surgery syndrome. They've tried physical therapy, injections, medications. They've been out of work for 8 months. They tell you they can't sit, stand, or walk for long without severe pain. If your note simply says chronic low back pain stable on meds, that patient is almost guaranteed to be denied. But if you write despite adherence to treatment, patient continues to experience chronic lumbar pain radiating to lower extremities, limiting sitting to 15 minutes, standing to 10, and walking to less than 1 block, that paints an entirely different picture. It's not advocacy, it's accuracy. It's describing reality in a way that the system can measure. I think sometimes clinicians hesitate to be that detailed because they worry it sounds pessimistic. But documenting limitations isn't pessimism, it's precision. It allows the medical record to serve both healing and justice. Now, let's talk about when you should start thinking about disability. For most chronic pain patients, the answer is sooner than you think. When you notice the pain is persisting beyond 12 months, that it's interfering with daily functioning, that work modifications aren't enough, that's when the question should be on the table. You don't have to raise it as you should stop working. You can frame it as, have you talked to anyone about disability support? Because once a patient stops working and has no income, it's much harder for them to access consistent care, refill prescriptions, or attend therapy. An early conversation allows them to prepare, gather records, and apply from a position of stability rather than crisis. There's also a misconception that applying for disability means giving up on treatment. It doesn't. It's not a moral failure. It's simply acknowledging that function has fallen below sustainable levels. And when patients apply early, while they're still in care, still supported, the documentation reflects that continuity. That's what Social Security looks for, a consistent, medically supported record that aligns with reported limitations. So where does a lawyer like me fit into all this? Ideally, not at the end of the story, but somewhere in the middle. Because when we can collaborate with providers early, when we can communicate about the kind of documentation that helps, we can prevent denials instead of appealing them. When you refer a patient for disability evaluation or legal guidance, it's not abandoning them. It's extending the continuum of care into the real world. It's saying, I've done what I can medically, but now let's make sure that you're supported practically. The best outcomes that I've seen are when doctors, nurses, therapists, and lawyers work together. We speak different languages, but we serve the same goal, helping people live with dignity despite chronic conditions. Let me share a quick story. A woman in her 50s, longtime nurse herself, developed complex regional pain syndrome after an injury. She kept working far longer than she should have until the pain made it impossible. Her note said, pain improved with medication, continues to function. That's what she told her doctor because she didn't want to sound like she was giving up. When she finally applied for disability, she was denied. Twice. When we reviewed her records, they showed a compliant, motivated patient, but no mention of functional decline. Her doctor absolutely believed that her pain was disabling. He just never wrote it down that way. We worked together to update her records with clear, factual descriptions of her limitations. At the hearing, the judge said, if this had been in the file from the start, this would have been approved 2 years ago. That 2-year delay cost her savings, stability, and peace of mind, all because of documentation language. I share that story not to place blame, but to highlight the power that you have to prevent it. Every pain specialist has seen patients whose suffering outlasts every medical intervention. Those are the ones for whom the system often fails, not because they're underserving, but because their pain is invisible in bureaucratic terms. When you translate that pain into clear, measurable limitation, you give them a fighting chance. So, how can you start applying this tomorrow? First, review your templates. See where you can incorporate one line about function, sitting, standing, lifting, concentration, attendance. Small tweaks can have a huge downstream effect. Second, educate your team. If your nurses or physician assistants handle note taking, train them to include functional details where appropriate. Third, encourage your patients to communicate openly about their daily challenges. Many downplay their pain in appointments because they want to appear cooperative. Assure them that honesty helps you help them, not just medically, but functionally. Fourth, when you suspect that a patient may not be able to return to work, mention it in your assessment. A simple sentence like, patient unlikely to sustain full-time employment due to chronic pain, can carry significant evidentiary weight. And finally, connect with local disability resources, legal clinics, advocacy groups, or law firms like mine familiar with Social Security practice. Having a point of contact means you can refer patients quickly and confidently when needed. Now let's step back and look at the bigger picture. Pain medicine is evolving. We're moving beyond symptom management into comprehensive quality of life care. That includes recognizing when pain becomes not just a medical issue, but a social one. When you integrate legal awareness into your clinical mindset, you're expanding your care model. You're acknowledging that treating pain isn't only about nerve blocks or medications, it's about protecting function, livelihood, and identity. And that's what the ACPA has stood for from the beginning, bridging disciplines to care for the whole person. When I work with clinicians who understand that philosophy, everything becomes easier. Their records are thorough, their patients feel supported, and the outcomes, both medical and legal, improve. It's not just that more disability claims get approved, it's that patients feel seen, validated, and safe enough to participate in their own care again. They stop viewing disability as defeat and start seeing it as stability. And stability gives them the foundation to manage their pain better, adhere to treatment, and maintain their dignity. That's what I want you to take away from this conversation. Not a checklist, not legal jargon, just an awareness that what you do, what you write, and what you say has ripple effects far beyond your clinic. You already heal pain. With just a little more awareness, you can also help heal fear. The fear of falling through the cracks, the fear of being forgotten by a system that often feels indifferent. So the next time you sit down to write a note or review a chart, take a breath and remember, somewhere, someone might one day read those words not as a doctor, but as a decision maker. And those words might decide whether your patient receives the help that they desperately need. And that's the quiet power of your profession. And that's how together we can create true support beyond care. Thank you.